Welcome to a MCCEE tutoring services video providing you with all your USMLE and Medical Council of Canada exam content needs. As always, check the description below to skip ahead to the section you want. You can also check out my website for more tools to help you do well on your exams. This presentation will cover the second video of the chest pain video series, Myocardial Infarction, Treatment. The most high-yield components on standardized exams in terms of myocardial infarction are treatment and complications. Today we'll cover treatment. Appropriate diagnosis, of course, is important. You need to remember that 2 of 3 of clinical signs and symptoms, EKG findings, such as the ST elevations in leads 2, 3, and AVF here, as well as the ST depressions in lead 1 and AVL, or elevated troponins are necessary to diagnose acute coronary syndrome. Let's start with a problem. A 63-year-old female with a past medical history of hypertension, hyperlipidemia, COPD, and diabetes mellitus presents to the ER with severe chest discomfort and shortness of breath for the last 30 minutes. The pain radiates to her jaw. The symptoms began while digging in her garden. ST elevations are in leads 2, 3, and AVF. What medications should be avoided until further testing is performed? ASA, oxygen, atorvastatin, or morphine? We'll come back to this later on. Treatment. You may have heard that door-to-balloon time is important. And in the case of STEMI, this is correct. In STEMI, you need to consider how long the symptoms have lasted for. If the signs and symptoms have been occurring for less than 12 hours, then PCI should be performed as long as it can be performed within 90 minutes if no TPA is available, or within 120 minutes if TPA is available. If the signs and symptoms have been occurring for more than 12 hours, then PCI nor TPA should be performed. If you need a moment to go over this slide, pause the video right now. Always remember, NSTEMI is not treated with PCI or TPA. It is only medical. Speaking of, let's go over NSTEMIs and STEMIs. Let's see how much you remember from the diagnosis video. What is the EKG finding here? If you need a moment to think, pause the video now. In leads 1 and AVL, you can see some T-wave inversions. You can also see them in leads V5 and V6. The ST segments are non-elevated, nor are they depressed, but that means this is still could be a NSTEMI if other ACS findings are present. Note, you must always check contiguous leads. So for NSTEMI and STEMI, what is the medical treatment? First is nitrates. If there's continued chest pain, it relieves the chest pain by decreasing the preload, but do not use if right heart failure is present, such as in inferior wall infarctions. Also, watch out for PDE5 inhibitors such as sildenafil. Beta blockers, if there's ongoing pain or hypertension, plus they decrease the mortality post-MI. You just can't use them if the systolic blood pressure is less than 90, the heart rate is less than 50 if they are in acute heart failure or ongoing bronchospasm. You can use a calcium channel blocker, such as verapamil, if a beta blocker cannot be tolerated or if there's recent cocaine use. Remember, it's only the non-dipyridamines that can be used in this case. ACE inhibitors or ARBs, they are only contraindicated in renal failure or severe hypotension, as well as morphine. It treats chest pain and pulmonary edema, but it does have a possible increase in mortality, and it is a vasodilator, so it is also contraindicated in right heart failure. Oxygen can be given as necessary, and statins are anti-inflammatory and help stabilize plaques. In terms of anticoagulation, ASI plus a PDY12, so an ADP receptor blocker such as clopidogrel, otherwise known as Plavix, or a GP2B or 3A inhibitors such as abciximab should be used, as well as heparin or fondaparinux or bivalirudin. It is very important to note that these slides are just a summary, and you will need to reference up-to-date or pocket medicine on precise guidelines of treatment, such as the dosages. If I went really in depth, you would have to listen to me drone on for at least an hour or more, but these should suffice for your exams. When looking at myocardial infarctions, it's always important to remember that arrhythmias are the most common cause of death post-MI. In particular, ventricular tachycardia and ventricular fibrillation are particularly deadly. Lidocaine is for ventricular arrhythmias only, and it can increase the mortality if given prophylactically instead of just for treatment. But always remember that if there is no pulse, you must do CPR. It is an easy to miss exam question, even if it does not come up very often. Another thing to consider is if there is no pulse, then you need to run through your appropriate ACLS algorithm. In summary, door-to-balloon time is important if signs and symptoms have been for less than 12 hours. If PCI can be done in 120 minutes or 90 minutes if TPA is available, then it is the preferred treatment. STEMIs, and NSTEMIs, medical treatment. Oxygen, nitrates for chest pain, as well as morphine, unless there is a 2-3 AV or inferior wall infarct or signs of right ventricular failure. ACE inhibitors and ARBs should be used unless there is renal failure, and beta blockers should be used unless there is heart failure, ongoing bronchospasm, or if the heart rate is less than 50 or systolic blood pressure is less than 90. In terms of arrhythmias, immediate complication concern is the arrhythmia and is the most common cause of death post-MI. Treat as per ACLS guidelines. Lidocaine is great for ventricular arrhythmias but has no effect on atrial. If a new AFib, you can use a beta blocker plus minus amiodarone. If no pulse, then you must do CPR. It is not a difficult question, so don't miss this on an exam. Let's take a look at our practice question again. If you need a moment to think about it, pause the video right now. The answer is morphine. Remember, whenever you have an inferior wall infarct, such as in leads 2, 3, and AVF, you need to check for right wall function, which can be done with a 15 lead EKG. If it is clear, morphine and nitro can be used, since both decrease the preload. This is the end of the video. Tune in next time when I will talk more about the complications of myocardial infarction, which is incredibly high yield for the Step 2 CK. This has been a MCCEE Tutoring Services production. Be sure to hit that like and subscribe button. For a link to the website, see the video description where you can learn more about what MCCEE Tutoring Services has to offer. Thank you, and have a great day.